Yeah, it's a great point and an important public health issue. So historically, over the last roughly 40 years, there's been this Gleason scoring system, which is basically how prostate cancer looks like under the microscope. And originally, it was Gleason 2 through 10, with 2 being the least aggressive and 10 being the most aggressive. And then over time, due to some advances in immunostaining, pathologists and clinicians realized that Gleason 2 through 5 really didn't meet the criteria of cancer, and it was kind of dropped from the cancer label. So for the last couple decades, it's been Gleason 6 through 10, and historically, Gleason 6 was routinely and aggressively treated, and thankfully, over time, it became apparent that people were being wildly overtreated and exposed to potential problems for the rest of their life. And so there was an effort that started in 2014 with clinicians and pathologists, basically taking the Gleason scoring system, which goes from 6 to 10, and trying to relabel it and calling it grade group 1 through 5, where for the most part, the 1 through 5 is analogous to the 6 through 10. And where we are in 2023 is that depending on which doctor you see or which region of the country or which part of the world, sometimes it's still referred to by the Gleason 6 through 10, and other places it's referred to as the grade group 1 through 5. Yeah, not just viable, but it's the preferred management in all national and international guidelines for people with grade group 1.
Mm.
And the reason for that is there's overwhelming evidence and experience that patients do extraordinarily well while on surveillance. And the intent is to try to minimize unnecessary treatment in these men. But each, region of the country, physician, parts of the world have different rates of surveillance for these men with grade group 1, and it's all over the map, which is unfortunate. Yeah, in my practice, it's almost everyone that has grade group 1, but there's a lot of really useful information that you can glean from each patient based on their PSA, something called the PSA density, how much grade group 1 they have. We tend to measure it in millimeters, their MRI findings, their physical exam. And there certainly are rare patients with grade group 1 where I recommend treatment, but the overwhelming majority go on surveillance. And then the intensity and type of surveillance really depends on, all those factors I mentioned, on whether they're really low risk of having problems down the road or somewhat elevated risk. Yeah, one of the challenges is that patients hear the word cancer and automatically associate it with something that is potentially aggressive or fatal or may impact their quality or quantity of life. And for grade group 1 prostate cancer, there's overwhelming evidence that even though it meets the microscopic definition of cancer, it's literally not capable of causing symptoms or spreading to other parts of the body. So there's a big disconnect in certain patients, and sometimes fueled by physicians, where they are understandably scared and concerned for a grade group 1, which has likely been in them for years or decades and is extraordinarily unlikely to cause them problems. Yeah, there's many management options for people with grade group 1. The most common ones are surveillance, surgery, or radiation therapy. For men who go on surveillance, the likelihood of that cancer ultimately spreading to other parts of their body and killing them is extraordinarily low. The most optimistic is a cohort of 1,800 men from Johns Hopkins, where at 15 years after starting surveillance, 0.1% of men had a metastasis from it. It's, basically 1 in 1,000 men. Sadly, in my opinion, in our country, 40% of men still undergo immediate treatment for grade group 1. And it is highly dependent on which doctor that they see. And it can range from 0% chance to 100% chance based on who they see. And there's other countries that have, variable rates that are either lower or higher than us. Yeah, there are a lot of factors, and it might be, there's a lot to unpack there. So sometimes it's what they've always done and they're resistant to any change or new data. Sometimes they authentically believe that recommending treatment in the form of surgery or radiation is the proper thing to do. Our healthcare system in the United States, in my opinion, somewhat unfortunately, has some perverse financial incentives where consciously or subconsciously that might play into recommendations. Really good news is we have made progress in this country where more men are undergoing surveillance. There was a time, 15, 20 years ago where less than 10% of people were doing surveillance for grade group 1. The last data we have is from 2 years ago where 60% of men were doing surveillance. In my opinion, it's been a slow adoption and not as impressive as it should be, because there are aspirational countries such as Sweden, England, Australia, where the rates of surveillance for grade group 1 are 90, 95% of men. Over the last 5, 10 years, there have been some very minor advancements, but nothing major in the form of surgery. There's little tweaks and changes in approaches that might slightly improve, the likelihood of having good function after surgery, but no major advances. As far as radiation goes, for early stage prostate cancer, there are some advances that are notable over the last few years. Probably most importantly, that the amount of total time needed to get your radiation therapy can be condensed down in many cases, and that's called hypofractionation. But first step before considering any treatment is always the important question of, does the cancer warrant treatment prior to embarking on that? Yeah, there are a lot of different scenarios, and there's not a clean, easy response, but it's basically someone who has, a reasonable life expectancy. They're getting screened for prostate cancer, and based on either the PSA or other blood and urine tests or an MRI, there's an elevated risk of having a grade group 2 or higher cancer that might ultimately cause them problems. So in that setting, a biopsy would be very reasonable and appropriate to see if there's a cancer there that might warrant treatment, either at that time or at some point in the future.